Welcome again, our colleagues. Today we will start a pediatric GIT session. This is a collection of most common of pediatric GIT anomalies and most common FRCR related cases. Anyway, let's start our first candidate. This baby, 2 months old male baby, presented with vomiting. Go on.
Okay, this is early 2 months old baby,
Yes.
X-ray abdomen and chest and abdomen,
Yes.
in which I can appreciate that there are multiple tubes and leads attached. Some of them are ECT leads. One of it is entering through the left apex and reaching the right side of the heart, and it likely is the central venous catheter. Both
Okay.
lungs apparently are normal without any ill-defined opacity or consolidation. Heart
Yes.
shadows within normal range. I
Yes.
cannot appreciate any spinal deformity, any hemivertebra, or any abnormal shaped vertebra. In the stomach, I can appreciate that there is paucity of gases and there are two
Extra.
well-defined lucencies seen projected over the abdomen. Sorry, sir.
Yes.
Okay. I can appreciate that there is the faint lucency seen along the left paracolic region, which might be bowel shadows that suggest that it might be an incomplete obstruction. There is no visualization of bilateral femoral heads, suggesting that it might be a prenatal delivery, which I would like to correlate with. It might be premature infant, which I would like to correlate with history. I would like to take the history from the mother of feeds. How is the baby's feeds? Because these two lucencies in the abdomen might be suggestive of duodenal atresia or incomplete duodenal atresia, or might be lead bands, or the small bowel malrotation can be an option.
Yes.
Next, I would advise contrast enhanced study or upper GI barium study for further evaluation.
What is this?
These are multiple ultrasound images of
Yes.
the same patient, in which I can appreciate that there is thickening along the pyloric region of the stomach, with protrusion into the adjacent uh, gastric cavity,
What is the name of
suggesting of antral
what?
sign.
What is the name of this protrusion?
Uh, Sir, it is antral sign
What else?
or mushroom sign.
Okay.
There are a lot many signs associated. Some
Uh,
of them are on the barium studies, some of them are on the ultrasound. It might be a nipple sign or an antral
yes.
sign or mushroom sign, but this protrusion is abnormal. This is
Yes.
quite characteristic of hypertrophic pyloric stenosis. In my routine practice, I would like to measure the whole length of the pyloric canal, a single transverse width of the single muscle, as well as the whole transverse width. If it is more than 17 mm of the complete length, then it is suggestive, quite characteristic of hypertrophic pyloric stenosis. I would like to communicate the findings urgently to the pediatric unit on call for further surgical option, and would like to discuss the patient in pediatric MDD for further management.
Thank you, doctor. What is the most recent management? There are a new era rather than surgical
Uh,
correction.
okay, sir, I think it is might be endoscopic pylorotomy.
Yeah.
Endoscopically, they resect the muscle.
Okay. What else?
Mm.
What else? This is a muscle. They can inject. Do you think they can inject anything within this muscle?
Botulinum,
Yes.
botulinum toxins.
Yes. 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 It is an option now. New era. If for sure the first line of treatment now is a surgical, but if some examiner ask you about the new era, I think we can add botulism injection. Okay.
Okay, sir.
Uh, One question: what is the normal longitudinal length from here to here? This one, the normal.
Sir, I think it should be less than 14 millimeter and more than 16 millimeter suggestive of HPS.
So it is a longitudinal lens. طب what is the normal of transverse? See, from here to here. This is transverse because this is axial. What is the normal? Not this one. This one from here to here.
Normal is less than 13 millimeter.
Okay, 13, 14 is acceptable. But what about this one? What is the normal? This is one limb of the muscle. Hmm. The
It should be less than 4 millimeter. Some
four,
books say 3.
yeah, okay, 4 of 3. So, what is your final diagnosis?
My final diagnosis is hypertrophic pyloric stenosis.
Congenital hypertrophic pyloric stenosis. Thank you, doctor, so much. See, my colleague, one advice for all of you. See, there are paucity of gas here. This is the finding, nothing else. So, if you tell the examiner, I suspect there are obstruction. Either because it is very proximal, and you see, we can see gastric air bubble and a nearby bubble here. Doctor, I suspect of duodenal atresia or CHIPS, congenital hypertrophic pyloric stenosis. My next step is ultrasound. Keep in mind, my doctor, ultrasound, especially in pediatric and neonate, whatever the pathology, ask for
Okay, sir.
ultrasound. Okay? Ultrasound,
Okay, sir.
ultrasound, even in adult, but in pediatric, ultrasound. Okay?
Okay,
Thank
sir.
you, doctor, so much.
Thank you so much, sir.
You did very well. See, my colleague, botulism is very, very common and proven a therapy for achalasia. Okay, but for chips, I think I listened from one lecture. It is one or two lecture. It may be used here, so it is better to tell the examiner surgical correction. If he ask you what else, what is the most new, I think he wanted to listen something about botulism. That is why. See, my colleague in UK, the hospitals there are يعني different research institutes. Some of them make a new era in one aspect, in MSK, in GIT, and each institute may have a specific regimen or treatment policy in some diseases. For example, if you search about the delayed hepatocytic specific antigen, you will never find overall at the Google or even the ChatGPT the procedure of 60-minute delay. Never. I search and I ask many people. I ask the head of Philips and Siemens. No one know about this. And finally, I after long research, this is a specific procedure related to specific hospital in NHS, one of the hospitals there. Okay, and I listen this information in one of Dr. Khan lecture. So يعني keep this experience, but the most common here is the surgical correction. Thank you, doctor, so much. Next candidate.
Assalamualaikum.
Salam. 1 second. Okay. Neonate presented with irritability and abdominal distension.
This is the upper GI contrast study in which I can appreciate that the contrast is seen opacifying the opacifying the esophagus as well as the stomach. However, the stomach is rotated and located in the right hypochondria. So I feel that the Hubble contrast is passing through the stomach into the distal bowel lobes,
Excellent.
which also appears to on the right side of the and the duodenal jejunal junction appears on the right side of the vertebrae. So I feel there is some malrotation present along with
Excellent.
gastric membranes. So I will immediately contact the referring physician and advise urgent surgical review for this patient.
Sure. Are you sure?
For urgency.
Yes, this is urgent. But before referring the patient, do you want to do another examination?
Yes, I will do the ultrasound of the patient
Why? What will you find?
for further confirmation for reversal of the vessels, for reversal of the vessels relation. Superior
What is
mesenteric vein, superior
what is the
mesenteric
normal?
artery.
What is the normal and what is abnormal?
Yes, on normally mesenteric artery is on left and vein is on right, but in malrotation they are reversed.
Why this emergency or urgency?
Because it can cause lead to perforation and obstruction.
Yes. From this, you didn't tell me the technique here. What is the name of this technique?
Technique,
Yes.
barium.
Yes.
Sorry, upper GI contrast study.
Okay. Okay. What else? It has a specific name. See, the contrast is in esophagus. We give it a specific name. Barium swallow. Okay. And
Yes,
when
yes.
the contrast in the stomach, it is barium male. But when the contrast down in the small bowel fall through, barium fall through. Okay. What is the specific or the pathognomonic sign here about the non-rotation?
Uh, non-rotation. Sorry, sir, I could not remember.
See, you see the stomach in the right side. So you told me, doctor, this is a non-rotation or mal-rotation, whatever. Okay?
Yes,
Okay, then
non-rotation.
what?
Sir, it is, I think, malrotation.
Okay, okay. But what is the most specific or pathognomonic sign? When you see something, you are sure this is
Right side of L1.
what?
Sir, the jejunal junction is located on the right of L1 vertebrae.
Yes, so from the beginning, it is better to talk about see, this is the stomach. Suppose this is the duodenum, okay? This the duodenojejunal junction, this one, okay? Even this the jejunum, it shouldn't be seen here. It should be seen here, okay?
Cox
Okay.
parens.
Oh, okay. What is the sign? What you didn't? What is the sign of volvulus? What is the name of the sign of volvulus?
Corkscrew parens.
Yes, okay. So see, corkscrew is a sign of volvulus. Volvulus, but the duodenojejunal junction in the right side of the vertebral column is a sign of non-rotation. What is the difference of non-rotation and malrotation? Do you know?
On non-rotation, whole of the duodenal
Excellent,
jejunal junction is on right side. Yes.
excellent. And the malrotation,
Malrotation, that some of the bowel loops have a reversal of their relation.
more than excellent. So my colleague, non-rotation is completely non-rotation of the bowel here, the small bowel here and the large bowel completely. But malrotation is a variant between the normal and the abnormal. Okay, like our doctor said, it is a variable degree, some and the some like this. Okay. Thank you, doctor, so much. Really, you did very well. So, my colleague, this is a case of non-rotation. If you told the examiner non-rotation, no, not a big deal. Um, I will tell you something negative about myself. I have been presented with this case in first exam, but the first was a plain film. Then, by the way, I told the examiner everything, but when I am telling him I will do ultrasound, I will see the superior mesenteric artery outer to or on the right of the inferior mesenteric, sorry, in the right side of the vein. I didn't mention this is the abnormal. So see our colleague what she did. She told me the normal is like this, and the abnormal is like this. And then I was surprised. Hello, I was surprised that the examiner misunderstand me. Okay, The examiner misunderstand me and consider me wrongly I answered. I think I didn't get a proper mark in this case. So, in some cases, you speak not loudly but very clearly, and it tells the examiner the normal is 1, 2, 3. The abnormal is like this. Because in the exam, everybody is stressed, everybody is confused, even the examiner. Thank you, doctor, so much. This is a surgical emergency because signs of corkscrew. Corkscrew sign is a sign of volvulus. So this patient presented with a vomiting. Doctor, last question.
Yes.
What is the most common presentation for this patient?
Pain and vomiting.
Vomiting. What type of vomiting?
Vomiting would be non-biliary vomiting.
No,
Non-bilious.
biliary. No, biliary. Why? Non-biliary,
Okay.
this is means above the second part of duodenum. But see, the corpus the volvulus is down, below the duodenum. Okay?
Oh.
Thank you, doctor, so much. Next candidate.
Doctor, there was also a stomach rotation as well.
Yes,
Gastric
it's
volvulus.
acceptable. يعني the stomach is a little bit يعني in the right side and this is abnormal. Okay?
Yes, yes. Okay, fine.
Okay. Next candidate.
Assalamu alaikum, sir.
Salam. Doctor, this patient has abdominal pain. By the way, my colleagues, by the way, today is a pediatric GIT, but this is means a pediatric related diseases. I mean what? I mean that this patient is 50 years old, but he have something related to the pediatric age. Okay? This
Okay,
patient
sir.
Okay, this patient is a 50-year-old male patient complaining of abdominal pain and vomiting for 12 days.
Okay, sir. I am presented with the CT abdomen post-contrast images.
Yes,
On this image, I can appreciate pancreatic head encircling the second part of the duodenum.
excellent. Yes,
While rest, I would like to see the rest of the images. In the visualized images, the rest of the structures are normal. Pancreas shows normal echo texture, no pancreatic duct dilatation, no retrograde CBD dilatation.
yes,
Gallbladder is normal,
yes,
and rest of the structures are normal. In the conclusion, it's a case of annular pancreas, which is encircling the second part of the duodenum. I would like to see the coronal images to see any retrograde gut dilatation. In
yes,
this case, or any free air or anything else, which is an emergency.
yes. Excellent, doctor.
Because it can, yes, sir.
Excellent. Let's go on. Go
Thank
on.
you, sir.
Go on. You have anything to say?
Okay.
Hmm.
I would like to see the coronal image to see any retrograde obstruction, and it also a cause of chronic pancreatitis in the patients. So, but there is no evidence of gallbladder stones, no evidence of CBD stones, no evidence of chronic pancreatitis in this case, like calcifications or duct dilatation.
Okay. In your opinion, what types of annular pancreas do you know? How many types?
Sir, it can be completely encircling the second part of duodenum. It can be partially obstructing the second part of
More than
duodenum.
do
But
you know the embryonic origin of this abnormality?
basically, it's a migrational defect in which pancreas not shifted properly and the cells encircle the second part of the duodenum.
Okay, so it is failure of rotation of pancreatic duct buds. We have two we have two buds of the pancreas, ventral one and the dorsal one. Okay,
Yes.
ventral and the dorsal one. The dorsal one that form a tail and body and part of the neck. Okay, this is the dorsal one, but the ventral one The ventral one is
Palm head and encinate process.
yes. So if you forget in the exam which one failed to rotate, tell the examiner failure of rotation of one of the pancreatic buds. At least the examiner will know, okay, this candidate knows the pathology, no problem which one of them, but at least he knows that the pancreas has two buds. Why? Because we have another disease called dorsal bud agenesis. Okay.
Yes, sir.
So like this, the examiner will respect you, and he will get a good feedback about you. Thank you, doctor, so much. Why this
Thank you,
patient?
sir.
Why this patient has vomiting? Because this is obstruction. Doctor, in your opinion, what is the the line of treatment here?
Sir,
The obstruction at the duodenum. Okay.
gastrojejunostomy.
Gastrojejunostomy. Okay, correct. Bypass operation. You mean bypass operation? Correct.
Yes, yes.
Correct. Very good. Correct. Thank you, doctor, so much. Look, my friends, see, this is the duodenum. This one. Okay, down, 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 completely surrounded by the pancreatic tissue. Okay. Unfortunately, this is a limited study, and really, I didn't find another one in radiology. But I think this annular pancreas, I think it is very good case. All of us should take care of it. Also, see, this is the two pancreatic duct. Take care of them because we have uh, two cases related to abnormality in the pancreatic ducts. Next candidate.
Sir,
Thank you, sir.
can you hear me?
Yes.
Okay.
Okay, doctor. Could you request control? This is a 15-year-old female patient with vomiting, upper and upper abdominal pain. Request control, please, doctor.
I cannot get the control, sorry, sir. Uh,
Did you request?
so can you scroll, please?
Okay.
Okay, so I've been provided with contrast CT abdomen and pelvis, also with oral contrast. The bladder appears normal. The bowel loops are mostly contrast filled. Uh, there is no abnormal bowel dilatation. I can see that there is minimal free fluid in the pericholecystic region. Uh, the the bowel loops, the duodenum appears mildly thick-walled with the surrounding fat stranding and reaction. Um, uh,
Perfect.
and
What else?
this appears in the second part of the duodenum. So given the pediatric age group and the thickening at second part of duodenum is surrounding free fluid, I would ask for history of trauma. Is there any
No
history of
history of
trauma
trauma.
in the patient?
See.
So, given the history of trauma and typical location of second part of duodenum, this is concerning for duodenal hematoma.
Doctor, 1 second. The duodenum is completely normal. Completely normal. See, I will show you. Save time. This is the stomach. Concentrate with the stomach.
Okay, okay,
This is the
okay.
pylorus.
First part of duodenum.
This is the duodenum. Okay. This is the duodenum. See, up.
Okay,
This is the duodenum.
okay. So,
You mean this
okay.
one?
So this is
Okay.
likely a head of pancreas. This appears to
Yes.
be head of pancreas, which
What
appears
happened?
significantly enlarged, and the pancreatic duct appears as dilated. Um,
Look
this
here.
could represent
Yes.
if there is history of trauma, this could represent an acute pancreatitis or pancreatic contusion
No.
likely due to trauma.
1 second, doctor. Doctor, 1 second. Look at the head properly, please. This is a dilated duct. Okay. Where
Okay.
where it is drain? Where?
Okay, so it is draining. This is the accessory bank. No, this is the minor duct which appears dilated, and the major duct at the major pampilla appears normal. So this is a case of uh, dilatation of the accessory of the minor duct. So I forgot the name of this condition. I'm really
No
sorry.
problem, no problem. What about
Okay.
the relation between a minor and the major?
There
Is
is no connection between the minor and major ducts. Only the
yeah.
major duct is dilated. The major duct is normal. The minor duct appears dilated, and it
So
is draining into the minor papilla.
excellent. What is the name of this disease? Disease.
The divisum. It is pancreatic divisum case
Excellent.
with suggestion of acute pancreatitis,
Okay,
given the fat stranding and reaction and enlarged pancreas.
okay. But how could you didn't forget it again? I will give you a very good sign. Okay.
Yes.
See, this is the minor duct and this is the major duct. Okay, both of them are separated, are divorced. Divorced means in the pancreas divisum. Okay, you will never forget it. Both of them are divorced. Okay, continue, doctor. So
Okay.
it is a divisum. Yes, you are correct. There are a complication.
So the complication of Davism is recurrent pancreatitis.
Excellent.
So this patient requires surgical consult for dilatation of the papilla, minor papilla, so that it can drain easily. So this requires surgical consult.
Okay, excellent. So what is the most common complication of pancreatic divisum?
The most common complication is recurrent pancreatitis, which can
Why?
lead to chronic pancreatitis.
Why? Why?
Because the papilla is very small, the minor papilla is very small, so it
Excellent.
cannot drain all the secretions. So it
No-
builds up and leads to pancreatitis.
Excellent, doctor. Thank you so much. Normally, the pancreas is drained by both of the minor and the major because there are a conjunction here or junction here. Okay, so and especially this is the most important. Okay, this is the main. When it came here, it drained at the ampulla of water. The ampulla, the opening here is more larger than the minor one. The minor duct drain in smaller duct, so the capacity of pancreatic secretion is exceeding the opening capacity. Finally, you will get this dilatation, okay, and surrounding smudged fat, see, denoting pancreatitis. This patient very commonly to have many recurrent episodes of recurrent pancreatitis, okay. And finally, you can find some, see here, there are some sort of atrophy here, really. Okay. Later on, you may find some calcification, and like this, if the case is neglected, if there are no any surgical correction for especially for this opening to increase its capacity. So it was a case of pancreatic deficit. How to retain in mind? See here, this couple of duct is divorced. Divorced means pancreatic deficit. D with D. Thank you, doctor, so much.
Thank you, sir.
Next candidate.
Assalamu alaikum, sir.
Salam. Could you request control, please?
Yes, sir. Sir, I have requested.
30-year-old female patient presented with recurrent abdominal pain.
Okay, sir. Okay, this is the MRI of a 30-year-old female patient presenting with recurrent abdominal pain. First, I'm going to scroll from top to bottom to see any obvious abnormality. And in this section, I can see that there is I can see that there is some abnormality within the pancreas.
Okay, where exactly?
They're at this level, head and body.
Yes.
Um,
What happened?
uh, the CBD is normal and it is entering into the pancreatic head at normal position.
Yes.
Pancreatic duct is also separately visualized.
Look again at the duct, please.
Okay, sir. The pancreatic duct.
Yes.
Okay. Now I'm tracing it. So I think there is some
Doctor, do you have a doubt about the duct?
what,
No.
sir?
Do you have a doubt about the duct?
Yes, sir. I am having some
Okay. One
suspicion
second.
that
One second. What is the next step? Or ask me for another sequence. If
MRCP. Yes, sir. I want to see it on MRCP.
I will give you. Okay. Take.
Okay. Okay.
If you
This
didn't
is the
ask,
MRCP.
if you didn't ask, the examiner will not give you. Okay.
Okay, sir.
See,
This is the MRCP.
one second. The last session of Sarah's our last session, Sarah's day, I
Yes.
gave one candidate a normal CT, completely normal, and he يعني try too much to pick up any signs, and I'm waiting for him to tell me this is normal. I want MRI because the patient has a clinical significance. Also, here the patient has recurrent abdominal pain. Okay.
Okay.
Yeah,
Okay,
go
sir.
on.
Okay, so this is the MRCP of the same patient, and in here I can see that there are the pancreatic ducts are dividing into two.
Thanks.
And I think there is also this is giving impression of pancreatic divism also as in the previous case.
Yes.
But it's sort of some partial divism. It's not through and through. I can see that they are being conjoined at the level of the neck and body of the pancreas, but they are draining separately into the major and minor papilla
No, see,
in the duodenum.
frankly, there are no, yeah, here, this is the tail, this is
Okay, sir.
body, neck, then to the minor. Okay? Here and
Okay.
the defend separated, but really the image is not the ideal one. Not the
Okay,
ideal.
sir.
Okay. Why I bring this case, my colleagues? Because today's session is dedicated for pediatric GIT. The value of
Yes.
session of today not to test you, rather than giving you a full information about each case or each disease. Okay, so this is the MRI of the pancreatic divisum. This is the MRCP. Okay, doctor. One question about the technique. What do
Yes, sir.
you think about the technique that used in MRCP?
These are heavily T2 weighted
Excellent.
sequences.
Excellent. What mean by heavily T2?
Um, so I guess there is some there is some difference of timing and no contrast is given in this study as far as I know.
Very nice strategic answer. Excellent. Very nice. Really excellent. Why? Our colleague did very well. There are a specific parameter for MRCP. Very specific. It is, by the way, called heavy T2 or the technique. You are correct. But exactly what happened? She didn't يعني, insinuate herself in too much physics. And she gave me a very political answer. Doctor, there are some changing in the parameter. So I shut mouth. I can't talk at all. Okay. I think they increase either TE or TR. I'm searching at
I
least.
guess there is increase in TE because it
Yes.
is heavily T2 weighted. Yes.
Yes, almost the increase in TE. Because
Yes, sir.
TE, whatever you increase the TE time to echo, you detect or you receive only the
Fluid.
highest
High sec-
fluid signal. Fluid
Yes.
signal. Okay. When you
Yes.
decrease the TE, you receive fat signals. Okay.
Okay, sir.
Thank you so much.
Thank you,
Last
sir.
question. Last one. What is the name of the techniques that generally used for abdomen or MRCP? Generally.
Generally, fat set techniques are done
Yes.
as and I guess and if the contrast has to be given, then T1 fat set post contrast are done.
Mhm.
And other techniques can also be done, but these are the most commonly done to see the abdominal viscera, and heavily T2 to see the fluid. And sir, I just know this.
Yes, no problem. This is an open discussion. Yes, you are correct. It is a fat, see, heavy T2, fat set, okay? Press holding techniques. Just you will tell the patient, hold the press in few seconds, 6, 10 seconds maximally. You will do acquisition of the whole slices. Why? Because they use very ultra fast technique like Husty, like Rare. This is the trade name, by the way. Okay.
Oh, okay, sir.
Because the patient can't hold the breath more than few seconds. Okay. By the way, my colleagues, this is a very sophisticated question, just for your knowledge. And if the examiner asks you this sophisticated question, means he will give you a very good mark. Okay, my colleague.
Oh,
So
okay,
again,
sir.
this is a MRCP. MRCP consists of fat set heavy T2 ultra fast technique. Okay,
Okay.
just
Okay.
press holding technique. Thank you, doctor, so much.
Thank
Next
you.
candidate.
Thank you.
Thank you. Next candidate.
Yes, hello, Dr. Rami.
Hello.
Yes.
Request control, please.
Okay. Requested. I'm presented. This is an barium upper GI contrast study. I can see that the contrast fills the stomach, pylorus, and going to the duodenum and going up to the jejunal loops, the proximal jejunal loops. And then I can't see the contrast go further. Okay.
Why didn't you scroll?
Okay, I thought it's a static study. Sorry.
Why did you listen to me to tell you the history?
Okay.
50-year-old female patient presented with dyspepsia and regurgitation. Okay.
Dyspepsia and regurgitation. Okay.
Yes.
This is a barium swallow. I can see that the esophagus seen filled with contrast.
Yes.
With the gastroesophageal junction seen below the left hemidiaphragm.
Yes.
This is the stomach, fundus of the stomach. I will scroll to check the images.
See, better to scroll with the arrows to take a slice by slice.
Okay. This is the last one. So the last image seen till the contrast reach the proximal jejunal loops.
Yes.
No other images. Okay, so I can't see any abnormality here. Just there is thickening of the gastric fold in the pylorus.
What else?
Um,
See, I'm scrolling by the arrows.
Okay.
What happened here between this and this? Concentrate.
There's
Yes, tell me.
thickening of the gastric rugae and
This is the normal. See, this is the normal. Why? Why? This, like this, like this, all are uniform. So this is the normal. See? This is even we should wait for fulfilling the stomach. But anyway, this is the normal. What else? You are very near from the answer, by the way. Mm. Let's start again.
defect. Okay.
Yes. Yeah. Where is the defect?
Defect here in the lesser what's it?
See, this is the lesser. Leave the mouse. This is the lesser curvature. Okay. All of this is good. This is the greater. All of this is good. What else? Where is the place or at which location the contrast is not completely seen? See, like what I mean. Here, normal. Why? The contrast is completely fill the stomach. Here is normal. Why? This is the rugae and this is the contrast. Here also, this is the contrast and this is the folds. Despite it's like a little bit increased, maybe, but there are, see بقى?
the jejunal cap.
Yes, excellent.
Okay. I can't appreciate the jejunal cap well. This is well.
What is, doctor, what is inside the jejunal cap? There are something inside.
The jejunal cap inside it.
See, this is the contrast. Completely fill the duodenum, except the fold. This is acceptable. Go trace all the duodenum and tell me what happened. Sorry.
This first part of the jejunum, second part.
Concentrate in the first part.
The first part of the jejunum.
See, is this one like this one? What is the difference between them? There are a difference.
It's narrowed. The first part is narrowed.
Okay, narrowed. Why? What is inside it?
The bilorojejunal junction.
Excellent. What happened inside it? Could you see the contrast completely?
No.
Okay, so what is inside? See, what is this?
Okay. This is ulcer.
Not ulcer. When we see something filling the lumen, what is the name of this?
Something filling the lumen.
Yeah, what is this?
Filling the.
Yes, excellent. Filling defect. Yes. By the way, the case is very difficult. This is a rare case, and most of us are not familiar with contrast. By the way, so step by step. So, what is this? Filling?
Filling defect, yes.
Okay, excellent. See, let's see it again. So there are a filling defect in the biloroduodenal junction. Give me a differential diagnosis.
Filling defect in the bilorojejunal junctions might be duodenal diverticulum.
Okay, what else? But diverticulum will be outside.
And okay.
What else? Mass. What else?
Maybe a mass
What else? Web, web, web. Okay.
Web,
So
okay.
a web. Oh, see my colleague. I am tracing the contrast from beginning. I did also see all of us inside the exam. Really, really, we are doing many mistakes. I think I see one case like this, but it wasn't the reporting, and I expect it is a static image. Then by luck, I don't know how I discovered it. It is not a static. It is a serious, very big mistake from my side. So look at any case and first, especially in reporting, because in Viva, the examiner will give you a notice. Doctor, this is not a static like this. And scroll one by one. Here, what happened? This is the stomach. The contrast completely fill the stomach. Don't judge about here the duodenum because it is collapsed. See, and you should trace the edge. All the edge. Is there are filling defect? Is there are doctor? There are a doubt here. There are a doubt. Why? The contrast here is not like here. Okay, let's see in the next. Doctor, it is increasing in hypodensity or non-contrast here. Look down. Oh, doctor, it is very clear. There are a filling defect here. And then give the examiner your differential diagnosis. Mass, lymphoma, ulcer, not ulcer. Don't tell us. Ulcer is a pouch filled by contrast outside. Diverticulum also is a pouch filled by contrast, but different from the ulcer by its margin is highly smooth, completely smooth, and the mucosa is normal. Okay, my colleague, I will give you, يعني show you another cases for ulcer and diverticulum, but concentrate here. Doctor, this is a filling defect. Can I see the other plans in other plan like oblique, like lateral? The examiner, if it is useful, the examiner will give. If it is not useful, the examiner will tell you, no, this is enough. Okay, this is filling defect for differential diagnosis. Number one, mass like carcinoma. Okay, lymphoma, web. Don't forget web. Why this is web? It give a little bit wind soak sign. Wind soak sign. It is a very common sign in duodenal web and also here. Wind soak sign. Okay. Let's today all of us search in wind soak sign. Okay. See my colleague. This is a very rare case. This is for me the first time to see a web here. And all of us are not familiar with the barium. Okay, by the way, if you have a pediatric case, don't tell the examiner this is barium study because almost we didn't give barium in pediatric. We give some water soluble. Tell the examiner this is a contrast. Okay, contrast, what is this? A contrast barium, sorry, a contrast swallow. Okay. A contrast male. This is male. Because يعني if it is fall through it must go at least to the يعني proximal area. Contrast. He may ask you if he asks you this is when you give barium, when you give water soluble, when okay, when he asks you like this you must answer. But from the beginning don't insinuate yourself and telling this barium and it may not be barium. Thank you, doctor, so much.
Thank you, doctor.
Next candidate.
عليكم.
Alaikum salam. Doctor, this patient, second, 1 day, and he is irritable and crying. By the way, many of the examiner will not give you يعني, a diagnostic history. Some history will give you a diagnosis. Most of them will give you a general history. يلا, go on, doctor.
This is abdominal radiograph for skeletally immature patient 1 year, 1 day old with irritability. I can see that there is a dilated lower colon.
Are you sure?
And
One second. Are
yes,
you sure
I
this
can,
is colon?
yes, because I see that the small in the background is dilated. So I call it lower GI, dilatation of the lower GI.
Are you sure?
I cannot,
Doctor, are you sure this is a lower GI?
yes, because yes, because there is no feature within these structures, and I think that there is cluster of small ball in the left upper quadrant of this patient. So
Excellent.
this makes this left colon.
Okay, go on.
I know that it is difficult to differentiate between small and
Yes.
large within the pediatric age group.
Yes.
So we call it upper and lower GI.
Okay. So it is
Second of all,
better to
yeah,
describe upper and or lower, and don't mention either this is colon, it is jejunum, because very difficult. Yes, go on.
but yeah, so yeah, there is dilatation of the lower GI. I cannot see gas within the rectum. Also, I cannot see any free gas within the abdomen. There is no evidence of pneumoperitoneum. Also, I cannot see any gas shadow or projection over the liver. I can see that there is also dilated structure seen in the right sorry, right fossa, right iliac fossa.
Yes.
So my impression appearances could be those of lower GI obstruction. I want to ask, there is a history of the patient pass meconium or not?
We don't know what is your next step, or what is your differential and the next step.
Yes. First of all, I will think about causes of lower GI
Yes.
obstruction. First, I will do clinical examination to see if there is any anal atresia or not. Second of all, I want to see if the patient is passing meconium or not.
Excellent.
If the patient didn't,
Hello?
if the patient didn't pass meconium, I am thinking. So can you hear me?
Yes, yes, go on.
Excuse me. Can you hear me?
Yes,
Yeah.
yes.
I want to see. Sorry, I have technical problem.
Go on, go on.
Yeah, I will do, but wait. My phone, someone was ringing. Okay. Can you hear me now?
Yes, yes.
Okay. So I am thinking about
Hello?
yeah, I'm the so I'm thinking about could be those of a meconium ileus. It could be due unlikely, but microcolon
Again, doctor,
or
doctor, tell me the differential list because your voice was interrupted. Again?
yes, I'm thinking about anal atresia. It could be due to anal atresia.
Yes.
Second of, it could be due to Herschel disease. It could be due to meconium plug syndrome and microcolon syndrome. Other differential diagnosis, it could be due to meconium peritonitis.
What is your next step, doctor?
First, I will do clinical examination to rule out anal atresia.
Okay.
Second of all, I will do lower GI contrast study to see if there is inversion of the ratio between the sigmoid and rectum to rule out sigmoid Soros-Branch disease, and then rule out the other pathologies.
Go on.
Yeah. This is a lower GI contrast study. In this study, I can see that there is dilatation of the lower GI and especially in the sigmoid colon with narrowing of the rectum colon. This is the reversion of the rectosigmoid ratio. Appearances are those of Hirsch disease. In my routine practice, I will confine my finding to referral doctor.
Sorry. Doctor, 1 second. Did you search all the series? Did you scroll
No,
it?
I didn't.
So we must scroll. You didn't even ask me.
Yeah. Okay.
This is the beginning. Tell us what happened.
Sorry.
What
Okay.
happened? Hey, what
So
happened?
we start to inject the contrast. I think the contrast passed until the sigmoid colon, which appears dilated with nerve of the rectum. And I can see that there is also a tube. I saw it in one of the images.
What else, doctor?
We scroll this.
Doctor, there are very important sign you must tell when you see this Hirschsprung contrast enema. What is the
Yes.
Oh, yes, tell me.
I can see that there is behind the arrow. I can see that the segment of severe stenosis or narrow.
Yes, what is the name?
It's like in middle of.
What is the name of this segment?
I don't know. I don't know. Remember the
What is the
name of the sign.
underlying pathology of
Aganglionic.
aganglionic?
Aganglionic. Yeah.
So what is the name of this segment? A ganglionic segment. Okay.
Aganglionic segment. Yes.
Okay. What else? Yes.
I saw aganglionic segment and irritation. That's all what I know.
Okay. What about the ratio between the rectum and the colon generally? Are you happy with this?
Generally,
yeah.
Yes. Usually, the rectum must be enlarged more than the colon, but here it is the reverse.
Yes. Tell me immediately.
So it is called reverse sigmoid ratio.
Yes. So there are a reverse of ratio. Reverse of ratio. Okay?
Yes.
Okay. So
yes.
Your final diagnosis?
Is Hirschsprung disease.
What is the underlying pathology?
A ganglionic segment of the colon.
A ganglionic segment of the colon. Okay. Why?
Yes.
Why? What happened in this aganglionic segment?
There is arrest of migration of the neural this produces this aganglionic segment.
So you are talking about abnormality in the mesenteric neural plexus. Okay. Thank you, Doctor, so much. Thank you so much.
Thank you, sir.
My colleague, one friend asked me just before the session about how to study, what is the most important source, and I promise him I will answer within the session. My answer is all of you almost have a good knowledge, but the most important challenge in the Viva, especially the Viva, is the technique. Why? Two of our colleague forget to scroll a series like this. Forget and start describing. For the examiner, it is a major mistake. Why? The main job of the radiologist to examine well, not each slice, every pixel here and here. So if you didn't scroll, you lose more than 99% of the information about this case. And يعني I didn't expect the examiner will forgive you. Okay. This is one. Doctor, by the way, this is a general advice for all. Don't take it. يعني
No, it is okay. No. I like your advices.
Okay. And by the way, I did mistakes inside the Viva exam. Once I forget to ask for another view in one X-ray. But we are trying to transfer you our experience because the target of all of us to pass. Second, you must stop here, 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 add the slice of importance and start to describe in short bullet containing a buzzword. See, if you tell the examiner, doctor, there are reversal of the ratio. The diameter of the rectum is smaller than the colon, and there are segmental neuron collapse, reduced diameter. This is called a ganglionic segment. My diagnosis is Hirschsprung. The examiner will, I will transfer the patient for surgical pediatric. Doctor, it is almost need a surgical correction. You smashed the case in 4 sentences. In 4. But when we are describing, doctor, this is a barium like this. The catheter is from down. The contrast is going up. Okay, this is too much verbosity. Too much verbosity, my colleague. Okay. Thank you, doctor, so much.
Thank
You
you. Thank you. Thank you.
did very, very well when you pick up. Our doctor really did something very nice when he noticed this. This is a small bowel, okay? The rectum is not seen, so it is almost large bowel or low GIT obstruction. Better in neonate especially, to use the term upper GI or lower GI. Lower GI obstruction start from anal atresia, then Hirschsprung, and colonic atresia. Colonic atresia and meconium plug syndrome. Okay, all of this okay. Meconium plug syndrome, not the meconium alias. Two different entity. Okay, my colleague. So when you are talking about lower GI, give a full differential. Why? Because really in neonate you will surprised after the contrast. I have one case like this, and it was very clearly uh, it is Hirschsprung from the X-ray, but after contrast another pathology. Okay, thank you, doctor, so much. Next candidate.
Thank you.
Hi.
Hi. Doctor, this patient has abdominal pain and distension.
Okay, these are series of spot films from micturating cystourethrogram.
Okay.
Patient having abdominal pain. I can see the I think this is the micturation phase that is in front of me.
Yes.
I can see that the urinary bladder shows mild trabeculation. However, I will like to see this on the initial films. There is grade 5 vesiculoureteric reflux on both sides with blunting of the calyces and tortuous ureters. The posterior urethra is outlined normally without showing any filling defects. However, I need to confirm this membranous urethra. The anterior urethra is also unremarkable. Sir, can I request for the remote control? I need to see the other. I have requested.
Go on.
Okay. In the initial films, the trabeculations are more pronounced with the small diverticuli. I'm looking for any changes in the spine, as this is the pediatric age group, and I could not see any filling defects in the posterior urethra. So in summary, in this pediatric patient, the MCUG showing irregular trabeculated contracted urinary bladder with the grade 5 vesiculoureteric reflux on both sides with the normal looking posterior urethra. So my principal diagnosis in this case is neurogenic bladder. I would like to see the spine to rule out further causes,
doctor,
and I will suggest.
Tell me from this contrast how to differentiate between what is your differential in general? What is your differential?
Sir, in this differential, my differentials would include posterior urethral valves and neurogenic bladder, and other differentials would include some stenosis in the posterior urethra.
Okay, what else? Posterior urethral valve, neurogenic bladder, and
bladder outlet obstruction due to some stricture.
okay. Okay. So how to differentiate between both of them, or yeah, between the three differential?
In the neurogenic bladder, it should be Christmas tree appearance. The unibladder is markedly contracted, and there are multiple trabeculae, and also there would be history of some changes, spine changes in the posterior urethral valve. There is a web-like appearance in the posterior filling defects in the posterior urethra. These could be circular or the longitudinal, and there is dilated posterior urethra with hypertrophy of the bladder neck. And in the case of urethral stricture, there is stricture I was suspecting in the third image during maturation. I was suspecting right over here in the junction of the, at this site of the membranous urethra. There was some, I need to look for the other series of the maturation film. Only the single film in the oblique view was available. However, in my close inspection, I can say that there is mild dilatation of the posterior urethra. I am suspecting this
Are you
could
sure?
be some filling.
1 second. Are you sure?
I need to look at the other images because I am suspecting right over here, although also the strictures in the membranous urethra and also one at the anterior urethra. In my
By the
normal
way,
routine.
by the way, this is slit is يعني not a posterior urethral valve. Why? If this is a posterior urethral valve, you should see here dilatation, visible, significant dilatation of the posterior urethra. What else?
Sir, I am suspecting right over here the small narrowing at the level of the membranous urethra and also at some point. In my routine practice, I usually see at the frontal projection, also at the oblique projection. To rule out, to further confirm the findings of this small narrowing, that is, I am suspecting at the membranous urethra and also somewhat
Doctor,
at the pediatric.
doctor, I told you this is normal. Don't worry about it. What else?
Okay, then this could be a neurogenic bladder that I.
Are you sure? Look the bladder here. See?
Sorry?
Look the bladder here in
No, the
the.
shape of the bladder is not contracted.
Okay.
Uh,
Mm,
yeah. However, there are small diverticuli and trabeculations are there.
Not too much, doctor. Is this the significant trabecular and the crest
No,
reappearance?
no, no. It is
So
not contracted.
what's your
So
what?
other could be bladder extrophy. Other differentials in this case would be bladder extrophy. However, I could not see any widening of the pubic symphysis in this case.
See, doctor, see. We did ascending cystourethropy. I think the urethra and the bladder almost normal, but what we find here severe bilateral.
Reflux. Then it could it be isolated with zygouriteric reflux
Yes,
on both sides?
yes. What is the degree of this reflux? Give
Sir,
me.
this is grade 5 because there is both ureters are tortuous and there is blunting. Markedly dilated bilateral renal pelvis is and the callus is blunting of the almost loss of concavity and whole of the calluses are blunted. So this is grade 5 zygouriteric reflux.
Excellent. So my colleague, thank you, doctor. Really, your style is amazing.
Thank you, sir.
Yeah. Don't worry. I make some pressure for you to squeeze your knowledge, but really, you have a very good knowledge. But don't hesitate. And this not a posterior urethral valve because really it in the real cases it is more thicker and it must cause dilatation here, proximal dilatation.
Yes, sir.
And yeah, and the
Sir,
bladder.
I
Yes,
normal practice I am reporting these MCUs.
yes. But do you think this posterior urethral valve,
Yeah.
yeah,
No, sir, usually it
will
is in the
cause
upper.
yes, will cause this marked يعني very severe bilateral reflux without affecting the bladder, without over distension and trabeculation and many multiple divertically. Too difficult بصراحة. Frankly, it is not possible. Second, the bladder here looks like normal. Okay, maybe this is one diverticulum or two maximum. But the most, where is the center of the pathology here? Here, here. Okay? So we must think about reflux. What is the degree here? At least 4 or 5. Okay? Because there are ballooning of kidneys, most kidneys. This patient, I think if he is neglected, he need urgent urological consultation because his kidney almost destroyed. You did very well when you told me I will look at the spine to rule out a neurogenic bladder. Neurogenic bladder give something called Christmas tree. What does this mean? It means it has a summit, irregularity. I wish you a case. I think I have one case for neurogenic bladder. Thank you, doctor, so much. Next candidate. Next candidate.
Hello, doctor.
Hello.
Hello,
Excuse me,
Assalamualaikum,
please.
sir.
Yes, Dr.
Excuse
Nagam.
me.
Yes,
Yes,
doctor.
I would like to excuse candidate 9.
Yes.
14 will go first because of urgent issue. Please.
Okay, please, our
Thank you,
candidate.
ma'am.
Do you mind?
Yes, sir. I'm candidate 13.
I'm candidate 10.
Okay, Dr. Nagam,
Okay, let me check just 1 second.
who will
13, yes. 13 will go first, please.
okay,
Yes.
please, doctor. Yeah, go on.
Uh, I am provided with frontal radiograph of abdomen of skeletally immature patient or an infant, showing multiple areas of lucency lining the wall of the bowel and mid abdomen. There is also evidence of dilatation of the small bowel. I cannot appreciate any linear lucency projected over the liver. Stomach bubble appears normal.
Yes,
I cannot appreciate any uh, free air under bilateral hemidiaphragm.
yes,
Uh, so I am thinking of nematosis intestinalis with evidence of, I think so. There is also a small bowel obstruction. Sir, can I know the history of the patient?
patient. Tell me the history of this patient. You should tell me what is the
Sorry?
expected history of this patient.
Sir, maybe this is a premature
Excellent,
infant.
Yeah, excellent. You are correct.
So at this point, I'm suspecting necrotizing enterocolitis. However, I cannot appreciate any evidence of any perforation of small bowel, but there is nematosis intestinalis and small evidence of small bowel obstruction.
Yes. What else?
So I would, sir, I cannot appreciate any other abnormality. I would convey my findings to referring physician and inform about my finding.
Okay. What else?
Sir, next ultrasound correlation.
Okay.
To
Do
look for small.
you have any clue of pneumoproteinemia here?
So there is no lucencies over liver, no free air under. I think so. There may be a lining of inner and outer wall of the bowel. So I would suggest the lateral decubitus to confirm the pneumoperitoneum.
What is
Free air.
the sign of pneumoperitoneum in this AP film? What is the expected sign?
So there may be a regular sign.
Okay, what else?
So there may be football sign if there is a large volume of free air in the peritoneal cavity.
Excellent. Excellent, excellent. So this is a case of pneumatosis
Sir, yes.
pneumatosis intestinalis due to prematurity. Thank you, doctor, so much. But this patient is maybe associated with something else. Look at this and tell me, maybe. Could you detect anything?
Sir, sir, there,
What
I
about the
think there
lung?
is only intraluminal. Sorry?
What about the lung? The baby is immature.
Sir, there may be some granular opacities in bilateral lungs.
Excellent. Correct.
Yeah, yes.
Correct. See the lung. There are some granularity,
Yes.
and the baby is immature. My
So,
colleague,
so maybe there may be surfactant evidence of some surfactant deficiency.
excellent. My colleague, this is a very
Yes, sir.
common case in either Viva or long reporting. Very common. Okay.
Yes, sir.
And the best view to see pneumoperitoneum is the chest.
Yeah,
Very
right, yes.
important. The chest. Why? You will see something here, central copular
Yeah.
sign, whatever. So it was a case of pneumatosis intestinalis, and I think the lung is not good. It may be respiratory distress syndrome also. Thank you, doctor, so much. Next candidate.